for the purpose of introducing our next witness.
Thank you very much, Chairwoman. Dr. Bort is a fellow Cincinnatian, as I mentioned before, and he's also a board-certified family physician and a fellow of the American Academy of Family Physicians. He's chairman of the board of directors of the Family Medical Group in Cincinnati, and after completing his residency at the University of Cincinnati in the Department of Family Medicine, he commenced private practice in 1986 with a physician partner. Since then, the Family Medical Group, which is a partner-owned practice, has grown to 12 physicians, 5 other healthcare professionals, and 86 employees overall, with over 28,000 patients, including me and my family, in 3 different Cincinnati locations. One of Dr. Bort's major areas of interest is headache diagnosis and treatment, as well as diabetes and other areas as well, but those are 2 of his special areas of interest. 2 years ago, the group implemented a fully integrated technology platform. Today, every person in the group utilizes a computer. Dr. Bort is a volunteer assistant professor of family medicine at the University of Cincinnati. He also serves on the advisory board of Crossroads Health Center in Cincinnati, which treats substance abuse. Cincinnati Magazine included Dr. Bort in their summer edition this year in 2008 as Best Doctors in Cincinnati edition. And we welcome him here today and look forward to his testimony. And all the other doctors have set a very high standard here, Dr. Bort, so we know you won't let us down.
Thank you very much. Chairwoman Velasquez and members of the committee, I'm honored to be here today on behalf of family physicians, my partners at the Family Medical Group of Cincinnati, Ohio, and most importantly, our patients. I'm a board-certified family physician and member of the American Academy of Family Physicians. I commenced practice in private practice in 1986 with my partner, Dr. Timothy McCarran. And since then, as Congressman Shah was kind enough to say, we've grown to 12 partners and 5 mid-level providers and 86 employees. We have over 28,000 patients. After waiting for years for the perfect EMR system, we decided in 2006 that it was time to invest in one. After investigating a number of systems, we purchased the MISIS EMR system, but found that converting our practice from paper to electronic records was an arduous process. Only our integrity and our desire to help our patients kept us on task. The report from the Institute of Medicine on the unacceptable number of avoidable medical errors stimulated our resolve. During the first year of installing the EMR, we actually had to decrease our patient load by 20% until we became more comfortable with the system. Now, with 2 years' experience, we realize that we deliver health care on a technology platform. Every employee uses a computer, and every patient encounter involves entering data into our EMR system. The experience has provided us some perspective on the cost, benefits, as well as the challenges associated with the use of EMRs. Cost. When we decided to convert to EMR, we didn't anticipate the ongoing cost of developing and maintaining a system. We purchased our system at an initial total cost of over $228,000, which did not include the transfer of existing paper files to an electronic format, nor did it include the time and effort required for the entire staff to become proficient and lost revenue while in training. However, we found that there is not only the upfront cost, as in the past year we paid over $258,000 to the EMR vendor. This is an annual expense that is not based on volume, but the reality of maintaining a system. One of the largest expenses was converting 25,000 plus paper charts to a format the EMR could use. This required scanning of important documents of each chart. We tried to do this on our own, but then resorted to shipping the remaining charts to North Carolina to be scanned professionally at a total cost of $80,000. Benefits. Convenience, accuracy, efficiency, and completeness are among the benefits of the system. For example, our patients can schedule appointments or request a prescription refill, which is then sent directly to their pharmacy. When I am with my patient in an exam room, I am able to access lab results or check past history all with the click of a mouse. This fosters better patient care because of our ability to track measures, benchmarks, and standards. We find privacy and confidentiality are enhanced with EMRs. With paper charts that were all over our office, there was no way to know who looked at the chart. Thus, it was near impossible to monitor HIPAA compliance. Now it is necessary to log on using password protection, and an audit trail is recorded down to the second. Finally, one of the most important roles that effective health of HIT, like an EMR, can play is to implement what is called a patient-centered medical home. This is a team-based healthcare model that emphasizes coordination of care that is particularly important for patients with chronic conditions such as diabetes. The EMR is central to the operation of a primary care practice that serves as a patient-centered medical home. Challenges. Our EMR uses an encrypted system to transmit information. While this acts to ensure patient security, it also poses a great challenge. When our doctors visit patients at some of the hospitals, we are unable to access the patient's information in our office because the hospital systems and our office systems are not compatible. Moreover, as family physicians, we interact with a variety of providers, such as my colleagues at this table. Laboratories, radiology, consultants, hospitals, nursing homes, etc. Each of these providers has their own computer system, but because they are not interoperable, communication from these various providers still requires paper. While I would like to say that we have achieved a paperless office, we continue to be inundated with paper. All day long, our fax streams hundreds of prescription refill requests to us since there is no direct electronic communication between our system and the pharmacy or other providers. The hospitals as well fax us reams of paper reports since thus far there is no standard for hospitals to electronically communicate with EMR. This amounts to several hundred sheets of paper which we must scan into the EMR, then pay to shred. Based on our EMR experience, I would like to offer two recommendations. Number one, due to the potential benefits, but in recognition of the substantial cost associated with EMRs, the investment and the utilization of HIT should receive some form of tax incentive or system of reward. Number two, Congress should foster an environment that provides incentives for the private sector to hasten the interoperability of EMR systems, workflow, and clinical data to promote low-cost solutions to enable quality measurement and improvement. In closing, both despite and because of our experience, I believe the benefits of EMR over paper charting are numerous and profound. But because of the substantial cost and time barriers, it is quite difficult for a small practice to convert to EMR. Yet we recognize how EMRs can improve the quality and efficiency of our care. We all share the goal of better outcomes at lower costs. Widespread use of healthcare information technology and electronic medical records are central to achieving that goal. Thank you for inviting me to testify, and I look forward to your questions.